In the name of God, the most gracious, the most merciful. Hello to all dear friends. Welcome to the Sir Nursing channel. Today, we want to talk about MS disease. We want to learn together the signs and symptoms, diagnosis and treatment methods, nursing diagnoses, and nursing interventions of MS. So without wasting time, let's get to the point. Multiple sclerosis is not just a disease of myelin, it is a disease of time. And every delay in diagnosis or treatment leaves a permanent neurological scar. Multiple sclerosis, or MS, is one of the most fascinating and devastating conditions in modern neurology. It primarily affects young adults, predominantly women, and silently reshapes the brain years before disability becomes clinically visible. In this video, we will go far beyond textbook definitions. We will explore what MS truly is, why early treatment matters, and how modern medicine is changing the natural history of this disease. Whether you are a medical student, a physician, a nurse, or any healthcare professional, this video is designed for you. Section 1. What is multiple sclerosis? Multiple sclerosis is a chronic, immune-mediated disease of the central nervous system, involving the brain, spinal cord, and optic nerves. For decades, MS was described primarily as a demyelinating disorder. Today, we know that this definition is incomplete. Modern evidence demonstrates that MS is a complex disease characterized by immune-mediated inflammation, demyelination, early axonal injury, progressive neurodegeneration. Crucially, axonal damage begins very early in the disease course, sometimes even before the first clinical symptoms appear. This is why MS is no longer considered a benign relapsing condition, but rather a disease in which time equals neurons. Section 2. Epidemiology and risk factors. MS typically presents between 20 and 40 years of age, with a female-to-male ratio of approximately 3:1. Key risk factors include genetic susceptibility, particularly the HLA-DRB1.15.01 allele, Epstein-Barr virus infection, now considered almost a biological prerequisite, vitamin D deficiency, cigarette smoking, alcohol consumption, shisha smoking, higher latitude and reduced sunlight exposure. MS is not directly inherited. Instead, genetic predisposition interacts with environmental triggers to initiate disease. Section 3. Clinical types of MS. Understanding MS begins with recognizing its clinical phenotypes. Clinically isolated syndrome, CIS. This represents the first neurological episode suggestive of central nervous system demyelination. Not all patients with CIS will develop MS, but many will. Relapsing remitting MS, RRMS. The most common form, accounting for approximately 85% of cases. It is characterized by acute relapses followed by partial or complete recovery. Secondary progressive MS, SPMS. Over time, many patients with RRMS transition into a phase of steady neurological worsening, with or without superimposed relapses. Primary progressive MS, PPMS. Approximately 10 to 15% of patients experience gradual neurological decline from disease onset without clear relapses. This phenotype is biologically distinct and more resistant to treatment. Section 4. Pathophysiology. What is really happening? At the core of MS lies an abnormal immune response. Activated T cells and B cells cross the blood-brain barrier and initiate inflammatory cascades, microglial activation, oligodendrocyte injury, axonal transection. Importantly, MRI visible lesions represent only the tip of the iceberg. Microscopic damage extends far beyond what conventional imaging can detect. This explains why disability may accumulate even when clinical relapses are apparently controlled. Section 5. Clinical manifestations. The clinical presentation of MS depends on lesion location and disease burden. Common manifestations include optic neuritis, presenting with painful visual loss, limb weakness and spasticity, sensory disturbances, ataxia and balance impairment, diplopia, often due to internuclear ophthalmoplegia. Among all symptoms, fatigue is the most frequent and one of the most disabling. Less recognized, yet critically important manifestations include cognitive impairment, depression and anxiety, bladder and bowel dysfunction, heat sensitivity, known as Uthoff's phenomenon. These symptoms have a profound impact on quality of life and must never be underestimated. Section 6. Diagnosis of multiple sclerosis. The diagnosis of multiple sclerosis is based on a careful integration of clinical findings, neuroimaging, and laboratory evidence. There is no single test that can diagnose MS on its own. The McDonald criteria. The McDonald criteria are built on two fundamental concepts: dissemination in space, DIS, dissemination in time, DIT. In other words, evidence of central nervous system involvement in different anatomical locations and at different points in time. The role of MRI. MRI is the cornerstone of MS diagnosis. Typical lesion locations include paraventricular regions, often described as Dawson's fingers, juxtacortical and cortical areas, infratentorial structures, the spinal cord. T2 weighted and flare sequences reflect disease burden, while gadolinium enhancement indicates active inflammation. A critical concept to understand is this: MRI can reveal disease activity even in the absence of clinical symptoms. Cerebrospinal fluid analysis. Cerebrospinal fluid examination provides important supportive evidence. The hallmark finding is oligoclonal IgG bands, present in the majority of patients. Their presence reflects intrathecal immune activation and can fulfill the criterion for dissemination in time, even after a single clinical event. Additional diagnostic tools. Other supportive investigations include visual evoked potentials, optical coherence tomography, emerging biomarkers such as neurofilament light chain. Neurofilament light chain is a marker of axonal injury and represents a promising tool for disease monitoring and prognostication. Section 7. Differential diagnosis. Not every white matter lesion is multiple sclerosis. Key differential diagnoses include neuromyelitis optica spectrum disorder associated with AQP4 antibodies, MOG antibody-associated disease, acute disseminated encephalomyelitis, central nervous system vasculitis, neurosarcoidosis, metabolic and infectious myelopathies. Misdiagnosis can expose patients to unnecessary and potentially harmful treatments. Section 8. Treatment of acute relapse. An acute MS relapse is considered a neurological emergency. The standard treatment is high-dose intravenous methylprednisolone in steroid-refractory cases. Plasma exchange may be required. The goal of relapse treatment is to shorten symptom duration and accelerate recovery, but it does not alter the long-term disease course. Section 9. Disease-modifying therapies. Disease-modifying therapies, or DMTs, are the foundation of modern MS management. The primary goals of treatment are reduction of relapse rates, suppression of MRI activity, prevention of disability progression, preservation of cognitive function. Therapeutic strategies. Two main strategies are currently used. Escalation therapy involves starting with lower-risk medications and intensifying treatment if disease activity persists. Early high-efficacy therapy involves initiating potent treatments early in the disease course to prevent irreversible axonal damage. Growing evidence strongly supports early high-efficacy treatment, particularly in patients with high-risk features. Classes of disease-modifying therapies. Injectable therapies. Interferon beta, glatiramer acetate. Oral therapies. Fingolimod, dimethyl fumarate, teriflunomide, cladribine, monoclonal antibodies. Natalizumab, ocrelizumab, ofatumumab, alemtuzumab. Treatment selection must be individualized, balancing efficacy, safety, patient characteristics, and long-term risk. Section 10. MS and pregnancy. Disease activity. During pregnancy. Most women with MS experience a reduction in relapse rates during pregnancy, especially in the second and third trimesters. This is believed to be due to the immunomodulatory effects of pregnancy, shifting the immune system toward a more anti-inflammatory state. Postpartum risk. After delivery, especially in the first 3 to 6 months, there is an increased risk of relapses. Close monitoring and planning of postpartum therapy is important. Treatment considerations. Many disease-modifying therapies, DMTs, are contraindicated during pregnancy due to potential teratogenicity. Some therapies, like glatiramer acetate and interferon beta, have relatively more safety data in pregnancy, but still require individualized risk-benefit assessment. Fertility and conception. MS itself does not impair fertility, and most women with MS can have normal pregnancies. Preconception counseling and coordination with neurologists are recommended. Delivery and breastfeeding. Vaginal delivery is generally safe. Breastfeeding is encouraged, though some DMTs may require temporary discontinuation. Balancing relapse risk and therapy resumption is critical. Summary. With careful planning and monitoring, most women with MS can have successful pregnancies without long-term adverse effects on disease course. Early consultation with neurology and obstetrics teams is essential. Section 11, Progressive MS and PIRA. In progressive forms of MS, the main challenge is progression independent of relapse activity, known as PIRA. In primary progressive MS, ocrelizumab is currently the only approved disease-modifying therapy. However, effective management extends beyond pharmacologic treatment. Rehabilitation, physical therapy, cognitive interventions, and symptomatic management are essential components of care. Section 12, The Future of MS Treatment. The future of MS treatment is increasingly optimistic. Current research focuses on remyelination strategies, Bruton tyrosine kinase inhibitors, cell-based therapies, including CAR-T approaches. The ultimate goal is not merely disease control, but restoration of neurological function. Multiple sclerosis is no longer a disease we simply react to. It is a disease we can anticipate, modify, and potentially redefine. Early diagnosis, early treatment, a long-term, multidisciplinary vision. This is how we change the future of MS. Now let's move on to the role and duties of a nurse in MS. The importance of the nurse's role in caring for patients with multiple sclerosis, MS. As we found out, multiple sclerosis, MS, is not merely a neurological diagnosis. It is a chronic, progressive, and unpredictable disease that affects nearly every dimension of a patient's life: physical, cognitive, emotional, and social. This is where the nurse becomes the cornerstone of care, not just a provider of routine interventions. The nurse has the most continuous and direct contact with the patient, is often the first to recognize subtle functional, psychological, or cognitive changes, plays a critical role in preventing disability, complications, and recurrent hospitalizations, serves as the patient's advocate, educator, and long-term support system. For this reason, a deep understanding of nursing diagnoses and evidence-based nursing interventions is essential for every nurse, from students to experienced neurological and ICU nurses. Common nursing diagnoses in patients with MS and nursing interventions. 1. Impaired physical mobility. Definition: limitation in independent, purposeful movement of the body. Related factors: demyelination, muscle weakness, spasticity, neuromuscular impairment. Defining characteristics: slow movement, gait disturbances, frequent falls, reduced range of motion. Nursing interventions: assess level of mobility and muscle strength regularly. Collaborate with physical therapy for ROM and strengthening exercises. Teach safe use of assistive devices, walker, cane, wheelchair. Reposition frequently to prevent pressure injuries. Encourage mobility within the patient's tolerance. 2. Fatigue, chronic fatigue. Definition: persistent feeling of exhaustion not relieved by rest. Related factors: central nervous system involvement, sleep disturbances, medication effects, depression. Defining characteristics: decreased energy, reduced concentration, inability to perform daily activities. Nursing interventions: schedule activities with planned rest periods. Teach energy conservation techniques. Monitor medication effects related to fatigue. Educate on prioritizing daily tasks. Refer to rehabilitation services when needed. 3. Impaired balance definition: inability to maintain stable posture. Related factors: cerebellar involvement, sensory deficits, muscle weakness. Defining characteristics: unsteady gait, fear of falling, frequent loss of balance. Nursing interventions: perform fall risk assessments. Ensure a safe environment, adequate lighting, remove obstacles. Teach slow position changes. Encourage appropriate footwear. Supervise ambulation as needed. 4. Risk for injury. Definition: increased susceptibility to physical harm. Risk factors: impaired balance, decreased sensation, muscle weakness. Nursing interventions: implement fall prevention protocols. Educate patient and family on safety measures. Ensure access to call light and safety equipment. Document and report all incidents promptly. 5. Impaired urinary and bowel elimination, neurogenic bladder, bowel. Definition: Dysfunction in urinary or bowel elimination related to neurological impairment. Related factors. Damage to neural pathways controlling bladder and bowel function. Defining characteristics. Urinary incontinence, retention, constipation. Nursing interventions. Monitor elimination patterns. Teach scheduled voiding techniques. Encourage adequate fluid intake. Prevent urinary tract infections. Collaborate with the healthcare provider for medication management. 6. Disturbed sleep pattern. Definition. Disruption in sleep quality or quantity. Related factors. Pain, spasticity, nocturia, anxiety, fatigue. Defining characteristics. Insomnia, frequent awakenings, non-restorative sleep, daytime sleepiness. Nursing interventions. Identify and address sleep-disrupting factors. Teach sleep hygiene practices. Adjust timing of medications and fluid intake. Create a quiet, low-stimulus nighttime environment. Refer for pharmacologic therapy if indicated. 7. Impaired swallowing. Definition. Difficulty in safe transfer of food and liquids from mouth to stomach. Related factors. Cranial nerve involvement, weakness of pharyngeal muscles. Defining characteristics. Coughing or choking during meals, weight loss, aspiration risk. Nursing interventions. Assess swallowing ability before oral intake. Position patient upright during meals. Provide modified diet textures. Encourage slow, deliberate eating. Refer to speech and swallowing therapy. 8. Chronic pain. Definition. Persistent pain related to neurological or musculoskeletal involvement. Related factors. Neuropathic pain, muscle spasms, nerve demyelination. Defining characteristics. Burning, stabbing pain, reduced functional capacity. Nursing interventions. Assess pain using validated pain scales. Administer prescribed analgesics. Implement non-pharmacologic interventions. Heat, relaxation techniques. Educate patient on pain self-management strategies. 9. Ineffective coping. Definition. Inability to manage stressors associated with chronic illness. Related factors. Unpredictable disease course, progressive disability. Defining characteristics. Denial, anger, withdrawal, emotional distress. Nursing interventions. Provide active listening and emotional support. Encourage expression of feelings. Teach coping and stress management strategies. Refer to mental health professionals when needed. 10. Anxiety. Common emotional responses in chronic neurological disorders. Related factors. Fear of disease progression, loss of independence. Defining characteristics. Persistent worry, low motivation, sleep disturbances. Nursing interventions. Screen for anxiety and depressive symptoms. Establish a therapeutic nurse-patient relationship. Educate patient and family about mental health support. Collaborate with psychiatric and psychological services. 11. Disturbed body image. Definition. Negative perception of changes in body structure or function. Related factors. Mobility limitations. Use of assistive devices. Defining characteristics. Low self-esteem, social withdrawal. Nursing interventions. Promote positive self-image. Encourage social engagement. Provide ongoing psychological support. 12. Sexual dysfunction. Definition. Alteration in sexual desire or function. Related factors. Neurological impairment, fatigue, psychological factors. Nursing interventions. Create a safe, non-judgmental environment for discussion. Provide sexual health education and counseling. Refer to appropriate specialists. 13. Risk for infection. Definition. Increased susceptibility to infection. Risk factors. Immunosuppressive therapies, urinary catheterization. Nursing interventions. Adhere strictly to infection control protocols. Educate patient on warning signs of infection. Monitor temperature and laboratory results. 14. Impaired cognitive function. Definition. Decline in memory, attention, and information processing. Related factors. Central nervous system involvement. Nursing interventions. Simplify instructions. Use memory aids and reminders. Educate and involve family members. 15. Activity intolerance. Definition. Insufficient physiological or psychological energy to endure activity. Related factors. Fatigue, muscle weakness. Nursing interventions. Adjust activity levels based on tolerance. Monitor vital signs during activity. Encourage rest periods. 16. Self-care deficit. Definition: inability to perform activities of daily living independently. Related factors: physical and cognitive impairments. Nursing interventions. Assess level of independence. Teach compensatory techniques. Involve family and caregivers in care planning. The nurse's role in comprehensive MS care. Medication management. Monitor effectiveness and side effects of interferons. Provide care during corticosteroid therapy. Educate on medication adherence. Patient and family education. Recognizing signs of relapse. Managing fatigue and stress. Home self-care strategies. Rehabilitation. Collaborate with physical and occupational therapists. Promote maximum functional independence. Psychosocial support. Provide emotional support. Reduce stigma and social isolation. Enhance quality of life. Long-term follow-up. Monitor disease progression. Prevent secondary complications. Clinical pearls for nurses caring for MS patients. Common nursing mistakes. Underestimating fatigue. Focusing only on physical symptoms while neglecting psychological needs. Nursing tips for shifts. MS symptoms fluctuate. Reassess every shift. Take even subtle neurological changes seriously. Care. During relapse period, reduce activity demands. Closely monitor neurological status. Provide strong emotional support. In the life of an MS patient, a nurse is more than just a caregiver. A nurse is a guide, a coach, an advocate, and a source of hope. If you found this video helpful, like the video. Share your experience caring for an MS patient in the comments. Subscribe to the Sir Nursing channel to stay up to date with future professional nursing content. Thank you very much for being with me in this video. Until the next video and tutorial. Goodbye to you all.